Hi, welcome student. Today we are going to tackle one of the most important OSCE topics in cornea, peripheral corneal lesion. This is the case-based discussion designed to think like a clinician, not just to memorize the facts. So let's begin with the real patient in front of us. Here is your clinical scenario. A 65-year-old patient walks in the OPD with complaint of redness, foreign body sensation and watering in the left eye. Here is the key detail. There is gradual increase in blurring of vision. So already in your mind, you should start asking, is this infection? Is this inflammation? Is there something systemic issue going on? Slit lamp examination was done and the pictures tell the story. What you see is the peripheral crescentic shape area of corneal involvement with redness, vascularization and thinning of the stroma right at the limbus. So now let us see the questions. So here is the 5 question for this case. First is the identification of this lesion of and describe its morphological characteristic. Second, what is the systemic disease should be ruled out to confirm the diagnosis. Third, mention 2 differential diagnoses. Next is the name the 2 steroid sparing agent used in this condition. Last is the what is the etiopathogenesis of this disease. You can pause this video and attempt to answer on your own. Okay. Now let us go through answer each step by step. So here the diagnosis is peripheral ulcerative keratitis or simply PUK. Now why does this happen? Let's understand the mechanism, because if you understand this mechanism, everything else, the treatment, association, differential will make sense. Okay, so PUK is fundamentally a type 3 hypersensitivity reaction. Here what happens? Step 1, in this a patient with underlying systemic autoimmune disease, there is antigen antibody complex which is formed and which is circulating in the blood. This immune complex get deposited in the limbal blood vessel. Why limbus? Because peripheral cornea has the rich vascular supply, making it the first point of immune complex deposition. Next step is, once the immune complex got deposit, the complement system gets activated, especially C3A and C5A. These are getting released. This will trigger further inflammation. So what happens is neutrophil and macrophil comes there and they start releasing proteolytic enzymes. These are matrix metalloproteinase, MMP1, MMP8 and MMP9. These are the main MMP which destroy and degrade the corneal stromal collagen. Second, what happens is when the stroma got degenerated, the epithelial start to break down. There is formation of ulcer and stromal thinning. And if the patient is untreated, it will lead to corneal perforation. So remember this sequence. There is immune complex which get deposited at the limbal blood vessel. Then it activates the complement. From complement activation, there is activation of macrophage, neutrophil. They will start releasing MMP protein. Then that MMP will lead to collagen meltdown. This is the mechanism for PUK. Second, now let's talk about the clinical feature and the etiology. So morphologically, the PUK has this characteristic appearance. It is crescentic shape, sometimes called moon shape. It shows progressive stromal thinning. There is limbal vasculitis. The vessels at the limbus will become inflamed. And if you see, there is epithelial defect. When we stain will fluorescent, it will shape positive staining. So what causes this PUK? What are the systemic disease associated with this disorder? First and most common is the RA, rheumatoid arthritis. The test to confirm is the RA factor anti-CCP. Anti-CCP is more specific than RA factor. Okay. Second most common is vaginal granulomatosis, also called GPA. Granulomatosis with polyangiitis. The marker are NCA, PNCA and CNCA. CNCA is the classical for vaginars. Third most common is the SLE, systemic lupus erythematosus. For blood test will be ANA and anti-double stranded DNA. Next is the PAN or polyangiitis nodosa. Marker will be MPO or myeloperoxidase antibody. So whenever you see a patient of PUK, your first thought should be, does this patient have a RA, or does this patient suffering from vaginal, or is it the SLE? This is not the just eye disease. It opens window to multiple systemic disorder. Okay. Now, what can mimic PUK? If you see this both corneal lesion, these are the most two important differential diagnoses. First, on the left hand side, you see a small peripheral lesion with stromal infiltrate. If you see that there will be a clear zone between the limbal blood vessel and this lesion, and this lesion is not touching a limbus, there is a clear zone that there is cap. So this is the clear cut definition for marginal keratitis. Okay, in this there is the gap between the limbus and the lesion. Second, on the right hand side, if you see, this is also ulcer. Here the patient will complain there is severe pain and it progress, and there is peripheral ulceration with overlying edges, and this is aggressive looking. So right hand side is our Murren's ulcer. This is differential from PUK. In following slide we will get to know how. So first is our marginal keratitis, second is our Murren's ulcer. So let's see. In marginal keratitis, it is caused by hypersensitivity to staphylococcal antigen. Staph directly doesn't cause cornea infection here, but antigen from blepharitis, staphylococcal blepharitis, trigger this immune response. This inflammation will sit on the cornea periphery, and there will be a clear zone between the limbus and this lesion. Okay, so for this, the treatment will be topical steroid with lid hygiene to treat the main source of infection which present in the lid. Now, second is the Murren's ulcer. Okay, this is very different from the PUK. In PUK, there should be some systemic association. If there is no any systemic association, we will call it Murren's ulcer. That is, it is idiopathic. We don't know any cause, exact cause, and it is extremely painful, and it has characteristic overhanging edges. This is diagnosis of exclusion. When you have ruled all the systemic disorder, when everything comes negative, then we'll tell this is Murren ulcer, not PUK. So what is the key point? Murren ulcer have no systemic association, whereas PUK will have systemic association. Moving to other differential, this is interesting because this is not an ulcer. It is degeneration and it is not inflammation process. Look at the cornea superiorly. The cornea is thin near the top. Okay, first is it is superiorly involvent. Second, if you see the leading edge, there is some whitish deposition. So this is lipid deposition. Third, if you see there is superficial vascularization passing from the limbus towards the cornea. Fourth is the epithelial is intact in this condition. There is no any epithelial defect. The fluorescence will be negative. So the diagnosis is Tyrion's marginal degeneration. So 5 characteristic is it is painless, it is superiorly involved, the cornea epithelium will be intact, and leading edge will have the lipid deposition, and it will cause against the rule astigmatism. Moving to next differential, again it is a degeneration. Here the location is opposite to Tyrion. It involves inferiorly between 4 to 8 o'clock. The key feature are there will be same progressive thinning inferiorly that will lead to corneal ectasia. And on topography, we have characteristic crab claw appearance. So any diagnosis which comes to your mind on topo the crab claw appearance? The diagnosis is PMD. It is pellucid marginal degeneration. Okay. So what we know, and it will cause severe irregular astigmatism. So it will be inferiorly involved. There will be corneal bulging, that is ectasia. And on topography, there will be crab claw appearance. It will cause severe irregular astigmatism. So now let us quickly compare between Tyrion and pellucid marginal degeneration, because they will ask in OSCE viva question. So for Tyrions, the location is superiorly. There will be lipid deposition. It will have superficial vascularization. The epithelial will be intact, and it will cause against the rule astigmatism. Whereas the pellucid marginal degeneration, it will be located inferiorly. There will be progressive corneal thinning with ectasia, no lipid, no vascularization, and on topography there will be crab claw appearance. Astigmatism will be severe and irregular. Trick to remember is Tyrian for top with lipid, pellucid for bottom with crab claw appearance. So let's compare two side by side. On the right side is the crab claw, bilateral inferior steepening with superiorly flat cornea, steepening on both sides inferiorly. Thus this is PMD. Right side, there is asymmetrical bow tie appearance, focal inferior temporal cone, one dominant hot zone, and there is asymmetrical of these lobes. So right side image is of keratoconus. Now going towards the treatment for this. Specifically for this condition, we are using steroid sparing agent. To understand how this drugs and why this drug, you need to understand how the immune system works. First, the antigen presenting cell, that is APC, present the self antigen to naive CD4 T cells. Second, the CD4 T cell will get activated and will start releasing IL-2 factor. Next step is this IL-2 will cause more clonal proliferation so that many T cell will get formed. Second, all this T cell which get formed, now they specifically differentiate into multiple effector cells, namely Th1 and Th17. That will start producing interferon gamma and IL-17. So this will further trigger to cytokine storm that will start producing TNF alpha, IL-2, IL-6. This will further cause more inflammation. Lastly, the B cell will get activated and they start producing autoantibodies. So all this will lead to PUK, corneal thinning, scleritis. Now we will see how each of these steroid sparing drugs acts and what all steps does this act. So there are major three classes of steroid sparing immunosuppressant. First class is calcineurin inhibitor. Normally if you see in OPD, they start giving cyclosporin and tacrolimus in case of severe dry eye. Okay, so first remember calcineurin is cyclosporin, tacrolimus. These are widely available. They work by blocking IL-2. They block the T cell activation signal. So they will reduce the IL-2 production. If IL-2 is less, then they will cause less clonal expansion of the CD4 cell. Second group is anti-metabolite. From the name, the term is anti-metabolite. So what they do, they will act on DNA synthesis so that the T cell in the clonal proliferation don't proliferate at all. So they are going to block it. Example of this drug is methotrexate, mycophenolate mofetil, and azathioprine. Okay. Now third class is they will block and damage the DNA which is formed in this cell. So they will act at cross-linking of this DNA. So permanently they are going to damage DNA of this multiplying cell. Example is cyclophosphamide, chlorambucil. Okay, this last set of damaging alkylating agent is reserved very in last stage in severe sight-threatening case. In case of vaginal granulomatosis. Okay, so remember first calcineurin will block IL-2. Example are tacrolimus, cyclosporin. Second is antimetabolite, which will block the synthesis of the DNA. Third is alkylating agent. It will destroy the DNA by cross-linking. Then the newer agent are biologic. These are the specific monoclonal antibodies. They will target the specific molecules or cells. So it will block specific cytokine and we have name for each drug. If some drug is blocking the anti-TNF agent, TNF alpha. So for name of that drug is adalimumab and infliximab. Second, anti-IL-6 agent. it will block the IL-6 signaling. Example is tocilizumab. Third, which will block the B cells, that is anti-CD20. It is rituximab. It will destroy the B cells. So autoantibodies won't get formed. So rituximab is the last resort when standard immunosuppression have failed. Remember, biologics are expensive, but they are life-saving in severe cases. Now let us see what all the questions have been asked, and we'll try to answer each one by one. So first question is, identify the primary clinical lesion with morphological characteristic. So the image demonstrate peripheral ulcerative keratitis, that is PUK. The morphological characteristic is it is crescentic shape or moon shape peripheral corneal ulcer. It's located adjacent to the limbus and there is no clear zone. It is associated with severe stromal melting and thinning, which further causes epithelial defect and which can stain positive with fluorescence. With that associated, there will be limbal vasculitis. So this is classical for PUK. This is our first question. Moving to second, what systemic diseases should be ruled out? The most important systemic disease is rheumatoid arthritis RA because it is the most common and it will cause a severe necrotizing scleritis that will lead to rapid corneal melting and perforation. What the investigation can be used for RA is the rheumatoid factor RF or anti-CCP antibody, which is more specific marker. Also, we need to rule out Wegener's granulomatosis with polyangiitis. We need to see with CNK, PNK. For SLE, we need to see with ANA, anti-double-stranded DNA. For PAN, we need to check with MPO antibody. And these are the other systemic association. Question 3 is, mention two differential diagnoses. First differential is the Murine ulcer. It is idiopathic. The systemic cause we don't know. It is very aggressive. It is painful and will cause peripheral ulceration. So key feature will be overhanging edges. There will be no clear zone, no systemic association, and it is diagnosis of exclusion when all the systemic causes have been ruled out. Second will be the Tyrian marginal degeneration. It is non-inflammatory process. It is located superiorly. The epithelial will be intact, no fluorescence staining, and association will be lipid deposition with superficial vascularization. It will cause against the rule astigmatism. Other differential, if they ask more differential, then it can be marginal keratitis. It is caused by it is caused due to staph hypersensitivity reaction. There will be clear zone between limbus and the lesion. Next will be PMD. It is inferior ectasia and there will be clap claw appearance on tomography. Next question is, mention the two steroid sparing agent. The two most commonly used agent is the methotrexate and mycophenolate. These belong to anti-metabolite. So what is the action of anti-metabolite is it blocks the DNA synthesis. Okay, it is given weekly. For severe cases, we can also use with cyclophosphamide. It is our alkylating agent. Rituximab for refractive cases. Monoclonal antibody. And see, steroid we can't give alone for months or year. We need to switch to steroid sparing agent. Next is, what is the etiopathogenesis for PUK? PUK is an immune mediated inflammation. It is linked with the systemic autoimmune vasculitis. Why the peripheral cornea is targeted? Because peripheral cornea has rich blood supply and there is abundance of the antigen presenting cells at the limbus. Immune mechanism is immune complex get deposited at perilimbal vasculature. There is type 3 hypersensitivity reaction in which antigen antibody complex get formed. With that, there will be complement system activated, that is C3A, C5A. They will attract neutrophil or macrophages. If both these cells are there, then they will start producing MMP, proteolysis of the collagen, stromal collagen, which will degrade it and it will cause stromal melting. Then if the stroma is melted, then it will cause further epithelial breakdown, epithelial defect, ulceration, and in severe cases, corneal perforation can also happen. So to summarize the today case, 65-year-old present with redness and progressive vision loss. She had peripheral ulcerative keratitis. The diagnosis is made purely on clinical basis because it is crescentic shape peripheral ulcer with stromal melt and limbal vasculitis. The systemic workup is mandatory. Start with RA, GPA, SLA, and PAN. The treatment requires systemic immunosuppression, not just eye drops. The differential will be Moran's, Tyrian, marginal keratitis, and PMD are distinguished by their location, presence of clear zone, epithelial integrity, and systemic association and topography. If you understand this mechanism, the topic will become simple. All the best for your DNB and MS examination. Thank you.